Christos Lambrakis. Thank you all for tuning in tonight. This is a first in a series of webinar presentations given by the Northeast Regional Epilepsy Group on a variety of topics in epilepsy and seizure disorders. And if you get a chance, please check out our website. I'll get the links at the end of the conference. These are the various webinars that we have upcoming. The next scheduled webinar is on March 5th, and that's with Dr. Fertig, and that's going to be new research in epilepsy. And you can see here we have webinars approximately on a monthly basis throughout the next year. So please tune in for those as well. Now, I'm a neurologist with specialized training in the field of seizures and epilepsy, and we call ourselves epileptologists. And epileptologists have spent extra time in their training, specifically in learning about patients with seizures and epilepsy. For many years, epilepsy was handled by general neurologists. However, with all the recent advances in medications and the various treatment options that are available, there really was a need for specialists within the field of epilepsy, and that's where the epilepsy training programs were developed. The goal of the epileptologist is to help the patient with epilepsy lead a full and productive life free of seizures, and to do that with the minimal of side effects from the condition, that being the seizures, or its treatment. Now, the brain is probably the most complicated structure in the known universe. It's composed of billions and billions of neurons. The neurons are the cells of the brain, and they communicate by using electrical signals. And in doing so, they control a whole variety of functions. And you can see here this representation of various things that the brain is responsible for. It's quite varied and quite complex. Now, what is a seizure? A seizure is caused when there's an electrical disturbance within the brain. Now, the brain, as we said, is composed of these neurons, the cells in the brain, and they normally send electrical signals to each other. And on some occasions, this electrical activity can become somewhat chaotic and result in this electrical storm that we call a seizure. During the time of this electrical storm, those cells, those neurons, cannot perform the function that they were previously doing. So if you have a seizure, let's say over the speech area of the brain, a person's speech may be affected. If you have a seizure that's occurring over, say, a motor area of the brain, a person may not be able to move their arm, or they may have jerking movements. It really depends on where the seizure is within the brain that's going to determine what the seizure looks like to the eye. Now, these slides will be available on the website, so don't feel that you have to frantically write everything down. All these slides will be available on the website. Now, here we have a electroencephalogram. An electroencephalogram is the main tool used by epileptologists. The electroencephalogram records the brain's electrical activity, and each one of these lines that you see, I have a marker here, each one of these lines that you see represents a different area of the brain, the electrical activity over a specific region of the brain. And this is a baseline normal EEG, and you can see here all these different rhythms, and these are all normal. Now, during a seizure, you can see here we have several seconds of normal EEG, and at this point, this is where the electrical seizure begins, and it's this rhythmic discharging that occurs. And this is the seizure, and this seizure goes on for each one of these big divisions is 1 second, so the seizure goes on for several seconds, and then stops abruptly, and it returns to the previous normal background activity. And this is the seizure electrically. This is what we see when we record an electroencephalogram during a certain type of seizure. Now, here's a picture of the brain, and as we said before, the brain is responsible for a variety of different functions, and depending on what area of the brain the seizure is coming from, you can see varied manifestations of that, depending on what area of the brain is stimulated during the seizure. Now, what is epilepsy? We use the term seizure and epilepsy quite a lot, sometimes interchangeably. And epilepsy is a state of recurrent seizure. So if somebody has a single seizure, we don't necessarily consider that epilepsy. However, if they go on to develop recurrent seizures, then we use the term epilepsy. Now, epilepsy is a tremendously variable term. It represents many different types of seizures, many different types of causes for the seizures, and responses to treatment. Now, our understanding of epilepsy has really increased dramatically over the last 20 years, and again, that's one of the reasons that the field of epileptology was developed, because of all this, all the developments across the board in treating patients with seizures. One of the main components of accurately diagnosing somebody is the ability to characterize the seizure, and that being through EEG monitoring. We'll talk more about that later. Also, the advances in seizure medication, of which there's been quite a rapid introduction of new treatments that are available, and some of the advances in surgery, epilepsy surgery, and vagal nerve stimulation. Now, epilepsy is one of the most common neurologic diseases. It affects approximately 1% of the population. That's about 2 million people in the United States. And approximately 10% of the population will have a seizure at some point in their lifetime, an isolated single seizure. So really those statistics tell you that, epilepsy is quite prevalent, with 10% of the population having a single seizure at some point in their life, and 1% having recurrent seizures for epilepsy. Now, on this graph, we have a distribution of the incidence of seizures over the age span, and you can see that here's the bottom, we have the age, and on the side here we have the incidence. And there are really two peaks here. We have during childhood, where we tend to see more seizures. Then it tends to stabilize during the middle age, and as we all get older, the incidence of seizures increases. Now, how do we go about diagnosing epilepsy? Now, the history of the seizures and the clinical description of the episodes are extremely important, and neurologists should really take the time to get the history and to really get a very good understanding as to what happens during the seizure itself. The patient is obviously interviewed as to what they perceive during the seizure, what happens to them, what do they feel, what's their aura, what happens during the seizure, are they aware of what's going on around them, as well as family members or people who may have witnessed the seizure, so they can give a description of the seizure. The other component is the electroencephalogram, and the electroencephalogram records the brain's electrical activity, and the electrical signature of the seizure is extremely important in helping us to better understand what kind of seizure a person had and what would be the best treatment for that type of seizure. Now, the EEG is a non-invasive test that's conducted either in the office or in the hospital, and the EEG records the brain's electrical activity. We do that by using approximately 20 electrodes over the surface of the scalp, and these are affixed to the head by using a paste. And we then try to record a seizure as well as the baseline EEG. So not necessarily recording a seizure is very important. However, the baseline EEG is also very important. What happens the brain electrically, even when the patient's not having a seizure. That information is also important, and ultimately helps us to characterize the seizure, determine where in the brain it's coming from. Now, here we have another EEG, and this is approximately 10 seconds of EEG. Again, each one of these lines represents the electrical activity coming from a certain region of the brain. And here you can see this what we call a discharge. This is what we call a spike. And a spike indicates that there's an area of electrical sensitivity within the brain. Spikes are not a normal finding, and they don't necessarily mean a person's going to have a seizure, but they tell us that there's an area of the brain that's electrically sensitive, and that this is a person who's likely to have a seizure. If this patient has a known seizure disorder, this type of finding is very important because it helps us to better understand where the seizure would be coming from. In the case here, this spike discharge is coming from the left temporal region of the brain, and the patient's seizures also came from this area of the brain, and we determined that later with further EEG monitoring. Now, during a seizure, the electrical pattern changes, and we see what's called an electrical, a rhythmic electrical discharge. As this seizure evolves, it begins to recruit more and more areas. So here you have the left temporal lobe. That's this group of electrodes, and you begin to see this rhythmic discharge. And this is the seizure evolving over the course of 10 seconds. And as the seizure progressed, this would get higher amplitude and begin to involve other areas of the brain as well as the seizure spread to different brain tissue. Now, this is a completely different patient, and this is another example of a different type of seizure. This seizure, rather than just staying in one specific area, spread to involve more of the brain. And here you can see that during the seizure, the rhythmic discharging really involves not just the left temporal, but also the entire left hemisphere, as well as the right hemisphere. So the seizure was more widespread in its involvement. Now, for years we were doing what was called routine EEG monitoring, and this is a procedure that's conducted typically in the office. It takes about a half hour. We would record the brain's electrical activity for that period of time. Many times abnormalities would not occur within that half-hour window, and we were missing a lot of very important information to help our patients. And Video-EEG monitoring was developed in order to record the electrical activity for a longer period of time, to look for these abnormalities that may not occur as often. For instance, a spike discharge may occur once every 3 hours. So if you do a half-hour EEG, it may miss that abnormality, and that's crucial. So Video-EEG monitoring allowed us to record for a longer period of time. It also allowed us to video the patient during the seizure itself, because a lot of important information is seen during the seizure. If we're able to visualize the seizure, what arm is involved? So does the head turn? Is the patient verbalizing or talking during the seizure? This type of information is very important to the epileptologist in terms of classification of the person's seizures. Now we're going to talk a little about seizure classification, and in general there's two types of seizures. We have what's called the generalized seizures and the partial seizures. Sometimes we use the term focal to describe partial. It's the same entity. The generalized seizures involve several different types of seizures. You can see the list here: the tonic-clonic, the absence, myoclonic, atonic, and tonic. Now, what differences are there between generalized and partial seizures? Generalized seizures involve the entire brain all at the same time. And this is a picture of the brain, and the electrodes that we place over the head are recording the area outside here, what we call the cortex. And the electrodes are recording the electrical activity from the cortex. And when we record a seizure that's a generalized seizure, all our electrodes are involved. So the pattern is different than a partial seizure, where only a specific region of the brain is involved during the seizure. What are the differences clinically? Well, when the entire brain is involved in this electrical storm, there's no brain that's available for maintaining consciousness. And patients that have generalized seizures will typically lose consciousness. Also, the motor areas of the brain, because they're being stimulated by this rhythmic discharging, will become activated. And this explains the jerking that occurs, or stiffening, because the person no longer maintains consciousness. The patient may not be able to breathe. There may be loss of bladder or bowel function. Tongue biting from the stiffening occur. And these are the things that we typically see in a generalized tonic-clonic seizure. Now, there are other types of seizures that fall within the generalized seizure category. One of the common ones is what's called an absence seizure, and these are the petit mal seizures that children will often have. And these are characterized by periods of staring. They're very subtle. They may not be obvious. The patient is usually unaware of their surroundings during these seizures because the entire brain is involved in the seizure. The seizure sometimes results in some rapid eye blinking or chewing. And commonly, children who have absence or petit-mal seizures are thought to be daydreaming, and it can take a while sometimes before the diagnosis is reached. Another type of generalized seizure is what we call an atonic seizure, or a lack of tone. These are the drop episodes that occur, and during certain types of generalized seizures, all muscle tone as well as consciousness is lost, and the person will fall to the ground. Another type of generalized seizure is what's termed a tonic seizure, and this just causes stiffening, abrupt stiffening of the extremities, and not the rhythmic shaking that we see in the tonic-clonic seizures. Now, the other common type of seizure class is what we term the partial seizures, and these seizures begin in a specific region of the brain. And depending on what area of the brain is being stimulated, you can see a whole variety of clinical manifestations. And if you recall those pictures that we saw of the brain from before, with all the different functions that the brain's capable of, a seizure occurring in any one of those areas may mimic the function of the area. So if you have a partial focal seizure that is originating from the occipital area of the brain that controls vision, the person may have some sort of visual phenomenon or visual hallucinations. If it's over an area of the brain that controls memory, like the temporal lobes, the person may have difficulty with memory. If it's over a speech area, the person may have difficulty with speech. So the types of seizures that we see with partial seizures are quite varied, and again, it depends on what area of the brain is being stimulated. Now, further within the partial seizure category, there are two types of partial seizures, the simple and the complex. And the difference there is that the simple partial seizures do not cause impairment of consciousness. So the patient may just have, say, rhythmic jerking in their right arm, but be completely aware, able to talk and communicate. During a complex partial seizure, there is some impairment of consciousness, and typically this is manifest by confusion. Now here we have a picture of the brain, and there is a seizure focus occurring in the motor area of the brain. So this patient would have some sort of motor phenomenon, some kind of jerking, stiffening of a specific limb, and without alteration of consciousness. So we would term this as a simple partial motor seizure. And here's another picture of a brain where we have a seizure that's originating in the sensory area of the brain. This person would describe some sort of sensory phenomenon, say in an arm or a leg. Maybe they felt numbness or tingling in a specific extremity, and they would not have any alteration of consciousness, and we would call this a simple partial sensory seizure. Now, a very common type of partial seizure, the complex partial seizure, which is a partial seizure with some alteration of consciousness, a very common type of seizure, originates from a region of the brain that we call the temporal lobe. And here you can see this is a cut surface of the brain, and this is the temporal lobe. And here we have a seizure that's originating in the temporal region of the brain. And this type of seizure would typically begin with an aura, maybe a deja vu sensation, maybe difficulty with memory, and then progress into confusion. Often with the complex partial seizures, we can see a variety of other phenomena, such as lip smacking, tapping, or fidgety type movements. And again, these seizures sometimes can be very subtle and difficult to pick up on. Now, what are the various treatment strategies that we have available to us to help our patients with seizures? And first and foremost are the seizure medications, and we'll talk about those, but we're also using more and more various surgical approaches for patients that are having difficult to control seizures, and also some dietary regimens which have been shown to be effective for helping our patients with seizures. Now, the goal of treating seizures with antiepileptic medication is to decrease the frequency of the seizures or the severity of the seizures. The antiepileptic medication treats the symptom of the epilepsy, the seizure. And the goal is to improve the quality of life by reducing the frequency of seizures, and to do that with minimal side effects. Now, a little history of the various seizure medications over the years. 1912, phenobarbital was introduced, and this was really the primary and only medication that we had available for treating seizures. It was very effective for treating the generalized tonic-clonic seizures, which we just learned about. and to a lesser extent the partial seizures. It unfortunately had no effect on absence seizures, which are very common in children. And it also had some side effect issues, primarily a sedative effect in many people. And sometimes we saw what's called a paradoxical reaction in children where they actually became hyperactive from the medication. In 1938, we saw the development of Dilantin, and Dilantin was shown to be just as effective as phenobarbital, but was less sedating, and that was nice. And Dilantin is still used today as a very effective seizure medication. Now, between the years 1960 to 1974, there was really very little in terms of treatments developed for seizures. The FDA imposed new regulations on the pharmaceutical companies, and this sort of makes sense, that the medications were now required not only to be safe, but to be effective against the illness they were designed to treat. So previously, pharmaceutical companies were releasing medications without really testing them adequately to see if they were effective against whatever disease they were being prescribed for, and that all changed with the FDA regulations. And it took a while for the pharmaceutical companies to catch up, and it wasn't until 1974 that we saw the next seizure medication. So we really went 20, 30 years without any seizure medications being developed. But in 1974, we saw the development of Tegretol, and you can see here the list of various medications that have come out more recently. And on the next slide, you can see here in the last few years, we've really had a rapid explosion of medications that are now available for our patients. And on this graph, we have the year with the various medications that were developed. You can see here's the phenobarbital and the phenytoin, and there was this long period with no medications being developed. And you can see here in the last few years just the rapid development of new seizure medications, and this trend will no doubt continue with the various techniques that the pharmaceutical companies have developed for investigations in patients with seizures. There have been some other developments with seizure medication, that being the expansion of the medication to extended release formulations, and these allow for easier dosing of the medication rather than taking medication 2 or 3 times a day. These medications can be given once a day. It's more convenient. It's for better compliance and less side effects. So that's a nice new development. And this graph just shows the concentration of a seizure medication, that being Depakote. And in blue, we have the, in black here, we have the regular formulation. And you can see how the blood level changes over the course of a 24-hour period, where you have these valleys where the seizure level is low. Here it's 70, and later in the day it comes up to 100, and then later in the day drops back down to 70. So typically with these seizure medications that you take 2 or 3 times a day, you'll see these peaks and valleys in the blood concentration. And this is important because patients may experience side effects at the higher end. So when the blood level of Depakote is above 100, here this patient could possibly have an issue with side effects. And then down at these low periods where it hits 70, this may not be enough medication to protect against their seizures. While with the extended release formulation, it's more of an even keel throughout the course of the day. There is some variation, but you tend to avoid the peaks and the valleys that you get with the regular medication. Now we're going to talk about some key concepts in anti-epileptic treatment. And the first one I want to talk about is the mechanism of action. How do seizure medications work? What do the seizure medications do to make the brain less electrically sensitive and help reduce the frequency of seizures? And there's a lot of unknowns, but there's also a lot of research that is being done to help us in better understanding what's going on at a molecular level to cause seizures. And what we believe is happening is that there are neurotransmitters. These are the signaling substances of the brain, the signaling molecules of the brain. And some neurotransmitters are what we call inhibitory, and some are excitatory. And the excitatory neurotransmitters are believed to be mediated in the development of seizures. Also, the cell membrane contains channels or pores that allow charged particles, ions of sodium and potassium and chloride, to move in and out of the cell. And we believe that this flow of ions, if something is wrong with the channels that allows them to either stay open too long or not close quick enough, that this can cause electrical instability and result in the seizures. And these are just some of the various mechanisms to target that the seizure medications are working to modulate. So if there's excess of a certain type of excitatory neurotransmitter, such as glutamate, some of the seizure medications may reduce the amount of glutamate. If there's too much flow of a certain electrolyte or ion, the seizure medication acts at the level of the channel to either open or close the channel so that it more mimics the normal function. And here we have this is a picture of a cell membrane, and this is the cell, and this is one of these channels or pores that allows the flow of charged particles. And you can see the charged particles here, and these move in and out through the channel. And if there's a problem with this channel normally opens and closes. If there's an issue with the channel, it allows these charged particles to cause electrical instability, which then could cause the seizure. Now, when do we treat patients with seizure medication? At what point do we decide that we need to use seizure medication? We don't necessarily start patients on seizure medication after their first seizure. The first question that we always ask is something truly a seizure? Is this something that may mimic a seizure? For instance, if somebody has a syncopal episode or an episode where they pass out, is that a seizure, or is that due to something else, like maybe an issue with their heart? So we want to make sure that we don't miss anything else that could be going on. We use the electroencephalogram to help us in evaluating the patient. If we see spikes, for instance, like we saw in the previous slides, that's helpful information. How often is the patient having episodes? Is this just a first episode, or has the patient had several similar episodes in the past? Are there any other neurologic issues? We do know that various neurologic conditions can increase the likelihood of further seizures, things like strokes, brain injuries. These can increase the chance of another seizure in the future. And what is the underlying cause of the seizure? Is there an underlying problem that could be treated rather than treating the seizure itself? Now, when do we decide not to treat? When it's a single seizure, most physicians, most neurologists and epileptologists do not place patients on seizure medication. If there's no previous neurologic history, if they're neurologically normal, these are patients that we would tend to wait it out and see how they do, as many of these patients will never have another seizure. A young person, we'd be less apt to put them on medications. And side effect concerns. We're obviously concerned about introducing a medication with potential side effects. Now, studies have shown that an otherwise normal child who has a single seizure, this is their first seizure, has only a 15% chance of having a second seizure if left untreated. So 85% of these patients will never have another seizure if left off seizure medication. And so typically a physician will wait for second or third seizure before starting treatment with the seizure medication. Of course, we're going to do an EEG. We're going to look at the neurologic history to see whether those odds would change at all. Now, if a child has a neurologic abnormality, like, say, cerebral palsy, some sort of metabolic or genetic issue, or the EEG is abnormal, this increases the risk of subsequent seizures to approximately 50 to 60%. So these patients, we may be more prone to put them on a seizure medication, even if it was a single first seizure. And we always assess the risk-benefit ratio. What is the risk to our patients of further seizures? What is the benefit of preventing further episodes? And what is the risk of side effects from using these seizure medications? And the decision to treat or not to treat is highly individualized. There's really no magic formula where we determine whether or not it's appropriate. It's really looking at the whole patient, the history, and using the various testing to help us in better understanding whether or not this is somebody that we want to put on a seizure medication. Another key concept in treating patients with seizures, specifically with antiepileptic medication, is a term called metabolism. And metabolism refers to the process by which medications are broken down and eliminated by the body. This is primarily done through the liver and to some extent the kidneys. Metabolism is important because when we introduce medication into a person, the body has to have a way of eliminating or getting rid of the medication. You just can't keep putting in medication into a body, or else the levels would continue to increase. So the body has a mechanism by which it gets rid of medication, and this is called metabolism. And metabolism is very important in determining a variety of things. Now, children have a faster metabolism than adults, and typically they require a higher than expected dosage of medication to maintain adequate blood levels. While older people have slower metabolisms, meaning that they often require less medication because their body's a little bit slow in getting rid of the medication. And often older individuals can become toxic on normal dosages of seizure medication. Now, another term and key concepts of anti-epileptic treatment is what's referred to as the half-life. The half-life is the time it takes your body to eliminate half the medication in your body. The half-life is determined by a 50% decrease in the blood level. Now, each medication has a different half-life. For instance, a commonly used medication like Dilantin has a half-life of 24 hours. So your blood level after 24 hours, if you were to stop taking Dilantin, your blood level would drop by 50%, by half, in one half-life. And for Dilantin, that's 24 hours. So after 24 hours, your Dilantin level would half. After another 24 hours, it would half again, down to 25%. After another 24 hours, it would half further, so down to 12.5. It takes about 5 half-lives to completely eliminate the medication from your system. On the other side, also half-lives are important as you start a medication. So it takes 4 or 5 half-lives of taking medication before the blood level builds up to the maximum amount. When you first start a medication on day 1, the blood level is 0, and it begins to increase from there. And it takes about 4 to 5 half-lives for the blood level to build up to where it's going to maximize out. Now, steady state is another term that is frequently used. Steady state refers to the balance between the amount of medication a person is taking in versus the amount that's being eliminated. And steady state may take several days. For instance, our example with Dilantin, with a half-life of 24 hours, it takes about 4 or 5 half-lives, or for Dilantin, 4 to 5 days to reach steady state. So every day the blood level's building, and at some point the amount that you take in is going to equal the amount your body metabolizes, and that's what we call steady state, and that's the blood level that we typically would measure. Now, the therapeutic range is a level of the amount of medication in a person's system. We will draw a tube of blood and send it to the lab and ask the lab to quantify for us the amount of medication. And for each medication, there's a different therapeutic range or therapeutic window, and this has been determined through years and years of research. The number that we get back is different for each medication. The reference range, or the therapeutic window, is different for each medication. For instance, Dilantin, the therapeutic range is between 10 to 20. And those two numbers were derived. The 10, the low number, is the level at which most patients need to be above to have any kind of seizure protection. So if a person has a level of 7, they probably don't have enough medication in their system to control the seizures adequately. The other number in the range, the 20, say the 20 is the point at which most patients begin to exhibit side effects. So that therapeutic range is the range that we look to achieve with the dosage of seizure medication. So when we get the number back from the lab, we look to see how it compares to the known therapeutic range. So for instance, a medication like Tegretol, the therapeutic range from the lab would be between 4 and 12. So we look to try and get our blood level between those two numbers. Now here you have an example of the the level of medication, the serum drug level, blood drug level of the seizure medication, and here you have time and half-life. And as we begin taking the medication, the blood concentration is 0, but as we begin to take it every day, you can see how the level begins to rise day after day, and at some point it begins to level off. And this is what we call the steady state. Here's the steady state being reached. So it's not going to go further. It's going to level out right here. And you're going to have this, what we call a peak and a trough, and that's the high point of the day and the low point of the day. But it's going to be higher than when you first started the medication. And what we try to do is aim to have the peak and the trough between the therapeutic range. We don't want the blood level to, for a certain point of the day, to go beyond the upper end of the therapeutic window. And we also don't want, on the other side, we don't want the blood level to go below the recommended therapeutic level here. So the epileptologist tries to keep the blood level between these two numbers in the therapeutic window. Now there are a variety of seizure medications that are available, and the important thing to remember is that each seizure medication works well for a specific type of seizure. The classification of the seizures are so important that the choice of medication really depends on what type of seizure a person is having. And again, that classification is determined through the EEG monitoring. It's very important, as some seizure medications can actually make certain types of seizures worse or ineffective. Now, these are some of the factors that we use in choosing a seizure medication. Obviously, the seizure type or seizure classification is one of the most important factors in determining what's going to be the most appropriate medication, and that's determined through the EEG monitoring. The syndrome of the epilepsy. We do know that certain types of epilepsy syndromes respond better to certain types of medications. What is the side effect profile of the medication that we're considering for our patient? Is this going to introduce side effects that may not be, may impede the patient, for instance, starting a medication that causes sedation in a child or a college student? Obviously, that's something that you want to avoid. The patient's age, their lifestyle, their childbearing potential. This is important for women who are contemplating having babies in the future. Many of our patients with seizures do have completely healthy, normal babies, but the seizure medications can cause issues, and we obviously want to prescribe something that is going to minimize that risk. And also what other medications the patient may be on. Various medications can interact with seizure medications. Now, monotherapy or polytherapy. Monotherapy refers to using a single medication for the treatment of seizures, and polytherapy is using several medications to treat a person's seizures. Now, monotherapy is usually preferred, and this is often how we start. We start with a single medication. We pick a medication based on the patient's seizure type, and we increase the medication as is required in small increments until the seizures are controlled or the patient begins to exhibit toxicity. At some point, if the medication is ineffective, we begin to reduce it and introduce another medication. Again, we always try to aim for monotherapy, that is using a single medication. However, sometimes we have to use 2 medications. Now, for most patients, 70 to 80% of the patients are controlled on monotherapy, so we don't have to use a second medication to control their seizures. Using monotherapy has fewer side effects, and there's not going to be any drug interactions between other medications. It's easier dosing and greater compliance and lesser cost. Now, for patients that are placed on monotherapy, about 70% of those are controlled, and approximately 30% continue to have seizures. Of this group, of this 30% that continue to have seizures, when we introduce a second medication, approximately 30% of that 30% is controlled. So you can see here that the initial control with monotherapy is very good. And as we begin to use polytherapy, the odds of controlling the seizures become less. So we always try to control the seizures first with monotherapy and then to use the polytherapy. Now the good news about polytherapy is about 30% of those difficult to control seizures with monotherapy can now be controlled. And there is some thought that using multiple medications can have synergistic properties, so that the effect of protecting against the seizures is additive with medication, like 1 + 1 = 3. Sometimes you can see that benefit from using 2 separate medications. Now, side effects. All seizure medications can have side effects. And some medications have more side effects than others. In general, the older medications, like Dilantin and phenobarbital, they tend to have more side effects than the newer medications. The type of side effects can be grouped as dose-related, dose-unrelated, or idiosyncratic. And the first one we'll talk about are the dose-related side effects. These are side effects that are related to the amount of medication the person is taking or the amount of medication in their blood. And these types of side effects cause things like sleepiness, slurred speech, difficulty walking. And the higher the dosage, the more those types of side effects occur. Now, the dose-unrelated side effects are side effects a patient may experience even at a low dose. And these include things like double vision, weight gain, hyperactivity. You can see the list there. Generally, these types of side effects are seen at the start of treatment and gradually get better with time. The idiosyncratic side effects, these are side effects that occur because of a patient's individual sensitivity, almost like an allergic reaction to the seizure medication. These are thankfully very rare, but they can cause some serious issues like liver failure, aplastic anemia, and rashes. These types of side effects typically occur early on in the treatment, and we're always on the lookout for those types of things. Now, these are some warning signs that definitely warrant a call to a physician to discuss. Things like prolonged fever, rash, sore throat, mouth ulcers, lack of appetite, increased seizures. These are just some of the types of side effects that definitely warrant a call to your physician to discuss. Now, pregnancy, all seizure medications pose some risk to the developing baby. None of the seizure medications that are prescribed in the United States are absolutely contraindicated. However, there is a risk across the board with all the seizure medications, and these typically are various congenital abnormalities, things like cleft lips and palates, which can be minor, to more serious things like cardiac abnormalities or spinal tube defects. Seizure medication can also reduce the effectiveness of certain types of birth control pills, so this is important information to discuss with your doctor before starting on seizure medication. Now, the FDA does classify seizure medications based on their pregnancy risk, category D being very high risk and category C being increased risk. And you can see here that the older seizure medications like phenytoin, Dilantin, Depakote, valproic acid, carbamazepine, Tegretol, and phenobarbital are in the high-risk category, while the newer seizure medications are in category C. So they have less risk. There's still a risk, however, but less than the category D medications. Now, approximately 75 to 80% of the patients with epilepsy will have reliable long-term control of their seizures with the currently available seizure medications. If we're having difficulty controlling the seizures with seizure medication, with monotherapy and then polytherapy, there does exist other options, including epilepsy surgery, neurostimulators, and the ketogenic diet. And we'll talk about those at the end of the lecture. Now, discontinuing antiepileptic medication. At what point do we discontinue seizure medication? And seizure medications certainly are not a lifelong commitment. Many of our patients are able to come off their medication at some point. At what point do we stop medication? Typically when we have some time under our belts without any recurrent seizures, and this is typically a period of 1 to 2 years of seizure freedom. We would want to look at their electroencephalogram to see what the electrical activity is, and if things look stable on the EEG, Once we withdraw the seizure medication, there's a good chance that patient is not going to have a recurrent seizure. What factors are associated with the recurrence of seizures if we're to stop seizure medication? The abnormal EEG in patients who have had a long period of seizure freedom. However, their EEG continues to show these irritated features like spikes. These are patients that I would probably not want to stop their seizure medication. I would recommend they continue with the seizure medication. If the seizures were very difficult to control initially, even though they may be under control now, these patients have a higher rate of recurrence once we stop their seizure medications. Patients with neurologic deficits, whether it's various congenital issues, whether it's things like strokes or brain injury, these patients, we know typically once we stop the medication, they have a higher rate of recurrence. And also the epilepsy type, the initial diagnosis of the classification, we know from experience which types of patients are going to grow out of their seizure. Now, what are some factors associated with non-recurrence in adults? And of the two types of seizures, that being the generalized or the partial seizures, the patients with primary generalized seizures typically do better off seizure medication. The younger the person, the greater the chance of coming off the medication. If we achieved easy control of their seizure medications with seizure medication, those patients tend to do better than somebody that we really struggled with getting their seizures under control. And again, 2 to 5 years of seizure freedom before we begin considering coming off seizure medication. Now, 65 to 70% of the children who are free of seizures on seizure medication will remain seizure-free after the medication is stopped. So that's a pretty good number there. Unfortunately, 30% of the patients will have a recurrent seizure, but approximately 70% of the children who have been seizure-free on seizure medication will remain seizure-free once they come off the medication. Now, I'm going to talk briefly about some of the newer treatments, newer seizure medications, and there is a webinar in the next few months that will address this in more detail. However, the pharmaceutical companies and the various research centers have been providing a lot of insight as to what is happening at a molecular level to generate the seizures. And the seizure medications are being developed at a molecular and genetic level to stop that process of electrical instability. The newer seizure medications are not just more of the same. They're typically unique mechanisms of action. They're targeting different things at the cell membrane level to stop seizures in patients that may not be having good control with more conventional seizure medications. The newer seizure medications tend to have similar effectiveness. They're generally not better, they're just different. So if an older medication doesn't work controlling seizures, the possibility that one of the newer seizure medications will work because it typically works through a different mechanism of action. Again, the newer seizure medications have their set of side effects, but in general tends to be less than the older medication. Some of the newer seizure medications may not be appropriate for all the different types of seizures, so it's really important to know what type of seizure a person's having before we place them on seizure medication. And most of the newer seizure medications are approved for adjunctive therapy, that is add-on therapy. So we typically don't use the newer seizure medications as monotherapy. We're often adding them on to a more conventional older medication. Now, these are some of the newer seizure medications that have come out recently. And Sabril, vigabatrin, was approved as a monotherapy for patients 1 month to 2 years of age with a type of seizure called infantile spasm. And it's also approved as an add-on therapy for adults with complex partial seizures. One of the main drawbacks side effect-wise is the risk of retinal damage, and that's why patients typically will have a eye exam, eye screening before and during the course of treatment. Banzel, refinamide, one of the newer seizure medications, was approved for the treatment of seizures in children and adults with Lennox-Gastaut syndrome, which is a common seizure type. Vimpat, Lacosamide, approved for add-on treatment in adults with partial onset seizures, and this was in 2008. This is a commonly used medication nowadays. Has a unique mechanism of action, low side effects, and works very effectively. Onfi, Clobazam, approved more recently in 2011, and this is another add-on treatment for the Lennox-Gastaut seizure syndrome. And it's helpful for the atonic, tonic, and myoclonic seizures. And these are just some of the newer medications that are in development, various stages of development. And many of these will probably eventually be FDA approved. In fact, this is from October. Verapamil was FDA approved for the treatment of partial onset seizures in children and adults. So there really is a lot of new things going on with respect to seizure medications, and the job of the epileptologist is to keep updated with all the new developments taking place. Now, just briefly, some of the other options beside seizure medication. These are various surgical or implantable devices, most common being the vagal nerve stimulator. Now, the vagal nerve stimulator is a pacemaker-type device, which is placed underneath the skin in the chest, and a small wire goes underneath the skin and attaches to the vagus nerve. The vagus nerve is a large nerve, what we call a cranial nerve, that exits from the base of the brain. And we use the vagus nerve because it's easily accessible in the neck. Surgically, this is a very straightforward procedure. And the electrical stimulus travels down the wire to the nerve, and we use the nerve as sort of the entrance ramp to the brain. And this electrical signal travels up into the brain and in some manner controls the electrical irritation of the brain and reduces the frequency of seizures. We're not sure how it works, but it's been shown in various trials to be effective in helping to reduce the frequency of seizures. It's sort of a novel approach. Applying an electrical stimulus is going to help with seizures, since when we do an EEG, we see that electrical storming take place. But this type of electrical pacing seems to stabilize the brain and reduce the frequency of seizures. Now, the vagal nerve stimulator was FDA approved in 1997, and it was also approved in 2005 for the treatment of depression. So you're seeing patients implanted with the vagal nerve stimulator, not just for seizures, but also for depression. The procedure itself is pretty straightforward. It takes about 1 to 2 hours under general anesthesia. And these are patients that typically have been on several seizure medications and who are having trouble, who were having trouble controlling their seizures through conventional treatments like seizure medication. One of the nice things about the vagal nerve stimulator is that it does run automatically, stimulating on and off throughout the course of the day, but by using a handheld magnet device, patients or caregivers can turn on the device as needed to provide extra protection for patients experiencing an aura or a seizure. The magnet is waved over the stimulator, and this turns the stimulator on at a special setting, and sometimes can abbreviate the seizure. Side effects, the vagal nerve stimulator has a very low side effect profile. Really, the main concern is a cough or a deepening of the voice during the time of stimulation, but this can often be improved by changing some of the parameters, and this can all be done remotely through a computer that we have in the office that's able to communicate with the device remotely. So we don't have to go back in surgically to change anything. We can change the settings of the vagal nerve stimulator through the computer in the office, and that just takes a few minutes. Now, approximately 1/3 of the patients with the vagal nerve stimulator will have a 90% reduction in their seizures, so that's pretty good. About 1/3 have a good response, and unfortunately, there's about 1/3 of the patients that have little to no response with the stimulator. So the stimulator is really a second-line treatment. Obviously, we try to control seizures with seizure medication, but in patients who are having a tough time controlling their seizures, the vagal nerve stimulator is certainly an option. There's been a lot of new developments surgically for things like deep brain stimulation, where electrodes are placed rather than say the vagus nerve, like with the vagal nerve stimulator, that the stimulation electrode is placed deep within the brain in the thalamus or the cerebellum, and then connected to a pacemaker-like device in the chest. And this is a lot of the new studies are being done. And here you have a patient who has one of these neurostimulators implanted within the skull, and the electrodes actually are on the surface of the brain, or in some situations deep within the brain, applying the electrical stimulus, which acts to reduce the frequency of seizures. And here's just another picture of that. Now this EEG is recording the brain's electrical activity, and there is a seizure that develops, and the pacemaker detects that electrical disturbance, applies a stimulation, and that electrical stimulation stops the seizure from propagating. Now, other newer treatments is epilepsy surgery. And epilepsy surgery, again, is reserved for patients that were really having a difficult time controlling their seizures. The epileptologist identifies the area where the seizures are coming from, the focus of the seizures. These are patients that typically have partial seizures. And assuming the partial seizures are occurring in an area of the brain that could be safely removed, and there are many areas of the brain that could be safely removed, the neurosurgeon would go in and remove that tissue where the seizures are coming from, and these patients do very, very well. A common type of surgery that's performed is what's called a temporal lobectomy, and these are patients with complex partial seizures who have seizures originating from the temporal region, and the neurosurgeon goes in and removes a part of the temporal lobe, and they remove that irritated tissue, and many of these patients go on to be seizure-free, and many of those patients were able to actually come off their medication at some point. Now, epilepsy surgery is certainly not a small procedure. It involves very careful brain mapping, and that's done through what we call invasive monitoring, where we actually put a electrode grid down on the surface of the brain directly, as opposed to the scalp EEGs. We put the electrodes down directly on the surface of the brain and record where the seizures are originating from. And once we have that information, then the neurosurgeon goes in and removes the tissue that we saw the seizures coming from. And here's an X-ray of what these invasive electrodes look like, sitting on the surface of the brain, recording the brain's electrical activity. And believe it or not, once these grids are in, they can stay in for several days, if not longer, recording the brain's electrical activity. And the patient is awake, eating lunch and dinner, and carrying on a normal routine in the hospital as we record the brain's electrical activity, trying to really refine where the seizures are coming from much more precisely than would be gained through the scalp electrodes. Now, some of the newer developments in treating seizures and epilepsy is the MEG, or the Magnetoencephalography, and this test measures the small electrical currents arising from within the brain. It's similar to the EEG, but provides greater accuracy in determining where the seizures are coming from. And it can also be used to map brain function, and you'll be seeing more and more of that used. The ketogenic diet is an alternative treatment for seizures. It was developed in the 1920s, and this is a high-fat, low-carbohydrate diet with adequate proteins, and it forces the body to burn fats, resulting in a condition called ketosis. And the ketones, the presence of the ketones, somehow stabilize the brain electrically, and these patients have a significant reduction in seizures. It is not an easy diet to adhere to. Again, these are patients that were really struggling to control their seizures, and there are some complications with this type of diet, including things like growth delay, bone fractures, kidney stones, and elevated cholesterol levels. Some of the other things that many of our patients partake in, alternative treatments for seizures, really anything to relax a patient. We have seen that things like stress, can go a long way in promoting seizures, not getting enough sleep. These are environmental factors that can affect a person's seizure threshold, and so patients use a variety of relaxation techniques to reduce their seizure frequency. Biofeedback is also a commonly used technique for that. Melatonin. Melatonin is in the news quite frequently. It's available over the counter. Most health food stores, pharmacies have it. It's a natural hormone produced by the pineal gland in the brain, and it's used as a sleep aid. And there was some thought initially that it may help our patients with seizures. However, subsequent research has really been inconclusive. So we're not quite clear on the role that melatonin has. Vitamins are necessary for good health. However, has not been shown to be of any benefit in large doses. Taking large doses of vitamins has not been shown to be of any benefit in reducing seizure frequency. On occasion, certain patients may benefit from taking specific supplements for things like calcium and vitamin D for bone health, as some seizure medications can deplete the body of these necessary vitamins. And that concludes today's lecture, our webinar on Introduction to Epilepsy and things that you need to know. If you have any questions pertaining to today's lecture, if you would be so kind to go to our website, epilepsygroup.com. There is a section up top called Ask Our Doctors, and there's an area there. If you could just write down your question and leave either an email or a phone number, and I'd be happy to get back to you and discuss the questions in more detail. Here's our two websites. Our main website, epilepsygroup.com, where you can get the links to this presentation, as well as the Ask Our Doctor section, and our Epilepsy Life Links, which is our resource center of the Northeast Regional Epilepsy Group. We have a lot of good information there for helping our patients with seizures and epilepsy. And just a reminder that the webinar schedule, which is also listed on our website, and the next webinar will be on March 5th with new developments in epilepsy by Dr. Furtick, and subsequently every month having more lectures throughout the course of the year. I'd just like to thank everybody again for tuning in, and please feel free to reach out through the website with any questions that you may have pertaining to today's lecture. Take care. Have a good evening.